Okay, let's get kicked off. Today the goal is to finish off our cranial nerves and get to the next topic after the cranial nerves are going to be diseases of the motor pathway. We'll look at things like ALS, Parkinson's, polio, whatever, CP, whatever. But before that, we're going to quickly finish off the cranial nerves. We'll look at a couple of some principles for treatment for vestibular patients. Then we're going to go over what? Audition and olfaction, and then we'll move into motor pathways. Okay, so quick review. Vestibular system, two major goals: control eye movements and posture and balance, right? So it maintains the vestibular system monitors our movement of the head in space, and it can control the body as a result of that, to compensate for stumbling or whatever. Okay, so that's going to be obviously the VSR, the vestibular spinal reflex, is the part of the vestibular system that controls the body, the posture of the body, balance, etc., etc. The other part is to control the movement of the eyes as a result of to balance that. Not to balance, but to maintain visual fixation on object. You don't want visual blur, that's worthless information, so every movement of the head one way, the eyes go the other way, and these vestibular ocular connections, of course, are the mechanism by which we control the movement of our eyes whenever we move our heads. And we looked at those here. We looked at the vestibular spinal tracts, lateral and medial. We looked at where the conscious perception of vestibular information goes via the ventral posterior nucleus out onto the cerebral cortex. Did we look at this? We'll come back to it. We've gone over most of those vestibular symptoms, haven't we? Spontaneous nystagmus. This is the pathological issue where you've got some vestibular damage. You get this twitching of the eyes. Nystagmus is, if it's right nystagmus, what would it look like? What does right nystagmus look like compared to left nystagmus? How do you name nystagmus?
Where the fast movement is too.
The fast component. So right nystagmus would be fast right, slow left. Okay? And that would be caused normally by head rotation to the right, of course. That's when you see that physiological nystagmus, but it's pathological. You're not moving your head and it's twitching. We went over the very basics. Is you can have downbeating and upbeating nystagmus. We won't go into that. Later on at PT, we'll have Sondra's class. You'll learn to treat and assess all these downbeating and upbeating nystagmus. Obviously, the eyes going up and down, twitching rather than side to side. You also have rotational nystagmus when they go and in miniature circles, twitching, like you're rolling your eyes, kind of thing. There's many types of nystagmus. Describe the very basics here. Head tilt, bowel rotation. You won't get that. That's for rats. I pulled this a slide I did when I did my rat work. They roll in a sort of lengthways position. That's bowel rotation in rats. We'll talk about that. That's the skew deviations are basically when the eyes squint to one side. They'll twist one side usually. Aim right. Both of them bilaterally would aim to the right or aim to the left. It won't be straight on in normal resting position. Oscillopsia, we're going to come back to this, but oscillopsia is basically, it's like if you close one eye and you poke yourself in the eyelid with the other eye, with your finger what happens to the visual field? Close one eye, poke yourself in the eyelid, and the whole world jumps, right? Like that. This flicks around. If you poke your eyeball, the eye jerks, and the whole visual world just flicks around like that. That's what oscillopsia is. Basically, you're standing there and you poke yourself in the eye. No. You're standing there and basically the visual world just twitches without you moving your eyes. The world seems to twitch. And that's just called oscillopsia. Vertigo, dizziness, falls. Obviously, we know what those are. We'll skip that. We're going to go cerebellum, vestibular cerebellum. Ways of testing the vestibular apparatus. This is obviously testing each part of the vestibular apparatus, which part of our balance system is damaged. So basically, remember, we get our balance from our vestibular system, our visual system, and our sensory system. So we can feel the floor under my feet moving, or pressure. I can feel my pressure increasing on my tiptoes, so I know I'm falling forward. That's the somatic sensory information telling me I'm falling forward. Okay? I can also feel my head moving forward. Vestibular information telling me that. I can also see the visual changes as I lean forward. I get close to the wall. So all those three pieces of information tell me I'm falling forward. Okay? And you can test all these three theoretically. I don't think this is a great test by this foam and dome condition, foam and dome test, or clinical test for sensory integration of balance. It's basically eyes open, eyes closed, and then eyes eyes open, but you're standing in with a dome over your head. So that makes vision inaccurate. Okay? You look at on the bottom there, it tells you which are inaccurate and which ones are accurate. You do those same three conditions standing on a lump of foam, which supposedly makes the somatosensory system invalid, inaccurate. Okay? What else do we talk about? Oh, Ducardis stepping test. Let's see if my video's working this time. I don't know if it will, but let's just try. There you go. There's a real vestibular patient who's doing Ducardis stepping test, and you step away for a while and see how far he moves, and you can measure the amount of rotation in a certain amount of time to give you an indication how severe it is. The other way of testing the vestibular spinal balance, and particularly vestibular spinal reflex, is this Berg balance scale. You've all seen that? OT, you've seen that? Yes? No? Yes? And it's basically 14 fill-in-the-blank, not multiple choice, fill-in-the-blank questions. You have the patient do various things, standing on one leg, pick an object from the floor, etc., etc., etc. And those are a very valid, very well-used tool for assessing a patient's balance. Okay. Let's talk about treatment approaches. If you're looking at the VSR for start, let's look at the VSR then VOR, so balance issues. So if your vestibular spinal reflex is off, if this apparatus is affecting your balance, basically you do a lot of balance training. It's pretty obvious, really, but you'll learn this in later classes, in Sandra's class. You'll look at how to improve balance, kind of perturbations, how you assess balance. But it's basically balance and gait training. We'll try to ameliorate those symptoms the patient's presenting with. Eventually, hopefully, it's the cerebellum that sees this mismatch, determines that I'm falling, I've got poor balance, and hopefully the cerebellum will start interacting with the vestibular apparatus to improve your balance. In some cases, you're not going to be able to improve the vestibular system balance, and you have to rely on the other systems. They're going to have to rely on somatosensory stuff. You might not know this patient has a vestibular damage until you do this foam and dome test, for example, or until you have them basically close their eyes. Takes vision away, they start swaying crazily. That's a very clear indication it's probably going to be vestibular apparatus damage. It might be somatosensory, but more than likely it's going to be vestibular. If they sway way more when their eyes are closed than when their eyes are open, you're thinking vestibular damage potentially. So you go through this very balanced training exercises, and you'll get to those in other classes, I'm sure. In terms of this is a treatment approach to the VOR, the vestibular ocular reflex. How would you treat that? How would you treat these connections between the vestibular system and the eyes? There's two broad theories of where you to treat this vestibular ocular reflex. One is adaptation, and one is habituation. So there's two principles you can apply to try and treat a deficient VOR. Adaptation and habituation. This is an example of adaptation. Adaptation, basically, you fix the gain of the system. You fix the system. You improve its ability. Habituation is you basically habituate the patient to those signs, those symptoms, until they get sick of it, get used to it, in other words, and it kind of gradually decreases. So this is an example here of treating the VOR using adaptation. You reset the gain between the eyes and the vestibular system. So for example, on the top one here, what you do is you have the patient hold a pencil, or you can hold a pencil or a pen or a playing card, and hold it still. And the patient slowly moves their head left and right while they're fixating on this thingamajig in front of them. Okay, slowly, and as they get better, they can go faster over time. So basically what you want to do is induce retinal slip, blur. And it's that blurring of the visual field that is a signal to the cerebellum to fix this mess. This is no good to me. So you give the patient this error information by just moving their head slowly left and right while keeping their eyes fixed on this thumb or whatever it is in front of you. That's called ×1 treatment approach. ×1. We'll see what I call it in a sec. The ×2 you progress to. Later on, as they get better, ×2 is with the treatment option down the bottom there. What you do there is the head moves left and right, but now the object in front of them moves the opposite way. So in other words, their eyes have to go twice the speed of the head. So in other words, when our head is turned to the right, like this, the object is sent to the left. And you do this kind of thing. Okay, so that's harder because my eyes have to go twice the speed of my head now. Because as well as my head going to my right, my fingers going to the left. So to be able to keep up with that, your eyes have to work faster. And you progress from that ×1 to that ×2. Again, it's providing the cerebellum, the brain, with error information. And it's that error signal is the thing that says, is the key to the stimulus to fix the gain of the eye movement. So you basically want the eyes to be able to keep up with the visual stimulus. Okay? That's called adaptation. You change the gain of the system. Can be effective, some people it won't work. The other thing you do, the other broad category is called habituation. Unfortunately, treating vestibular patients is not very nice. It's not a nice thing to do because basically the principle behind the treatment approach is do whatever makes you feel bad. In a sense, make the person feel dizzy, make the person feel nauseous over and over and over and over again until you habituate to it. You get tired of it and you gradually decrease the severity of those symptoms. So you'll do these things that will provoke dizziness, nausea, whatever it is. So if it's a VOR, things like patients report to you, for example, shopping is a big pain. Because they're walking down the aisles with a shopping cart and they twist their head to look for the cereal box, which one they want. They're doing this kind of stuff. That makes them feel sick in some of these patients. Because the head's moving and the eyes are looking at different boxes of cereal, whatever it is on the shelves, and they'll feel sick doing that. So you make them do it. You set up things in a clinic that will test this VOR and make them feel nauseous, I'm afraid. They've got to basically overcome it. Get used to it, suck it up as it were. I mean, it's a bad way of looking at it, but you've got to make the person habituate to these signals. So these people, instead of, so what they'll do, if they feel nauseous, they'll go down the shopping cart alley like this. They're guarding. They don't want to twist their head around and do this stuff because they know they go, oh, I feel horrible. So they're going to guard themselves and they're going to do this kind of motion to see things. They're going to not make themselves feel nauseous, obviously. But basically they're not getting a stimulus then to repair themselves, habituate. So you basically invoke those symptoms. You force them gently at first, whatever, to get used to these things and supposedly to habituate and then gradually symptoms will gradually decrease. And you will, as I say in later class, you do a lot more of these kind of things in treatment of these things. Very quick, we'll finish off by looking at 3 typical common problems you'll get in problems with vestibular apparatus. I think we mentioned this one before, unilateral vestibular hypofunction. This is basically one side of the apparatus, left or right, whatever, basically decline in its function. The hair cells on one side die off for some reason. And often it's aging will do it. Parkinson's disease has this problem. Diabetes often. And multiple sclerosis. Many diseases can cause this unilateral vestibular hyperfunction. Basically, one side is not signaling as much as it should be because the hair cells are diminished. And remember, at rest, the key thing, at rest, we have both sides signaling, don't we? Remember those kind of cilium and stereocilium standing straight up? When they're standing straight up, they have a background firing into the vestibular nuclei. If they deflect one way, you get inhibition, and you get decreased firing. If they're deflected the other way, you get increased firing. So at rest, you have background firing from both sides. Now, if one side decides to die off, the hair cells on one side die off, that background firing from the right-hand side, for example, will decrease, which suggests there's movement. If you have unequal input from two sides, it means the head is moving. And obviously these people are not moving. The somatosensory system, the visual system says I'm not moving, but the vestibular system says you are moving. So you get all these problems like equilibrium off, vertigo, gait ataxia, poor balance, basically, nausea. Often you find oscillopsia with these patients. You might find nystagmus with these patients. Any of those typical vestibular symptoms you might see with unilateral vestibular hyperfunction. You might see skew deviations, where the eyes skew one way, bilaterally, and they will skew to the side of the lesion. So if I've got right vestibular hyperfunction, the eyes will skew to the right. Okay? You can treat this. I mean, eventually, hopefully, the cerebellum will balance those inputs. The cerebellum goes, well, yeah, there is an unbalanced input from these two systems, left and right. But everything else from the body tells me I'm not moving. So it won't go through these pathways, but the vestibular cerebellum gets all this information from their senses. The only one that's wrong is the vestibular system sending information. So it can reset the balance between those two systems, hopefully, if it's not too severe. Particularly when you provide these treatment options where you provide the vestibular system or the cerebellum with this error information. They basically reset the system, hopefully, to the mossy fibers and all, whatever. We won't get into all that details of that, but the vestibular cerebellum is the key point, the key controller here that can adjust the gain of the cerebellum. Okay? Meniere syndrome. What's his name? Prosper Meniere. He first came up with this diagnosis in 1861. This French bloke. You can't do much about this, I'm afraid. But you will see patients come in with this, and there's not a lot you can do. This is unknown etiology, generally speaking. You don't normally. It's idiopathic. It can follow head trauma sometimes. Sometimes it follows middle ear infections of the middle ear and inner ear. But generally speaking, most of this is idiopathic. So what these patients present with, one of the obvious things they'll say is tinnitus. Have you heard of that term, tinnitus? Ringing in the ears. It's usually unilateral. So it's one ear, one side getting whining, ringing sound in one ear constantly. Not constantly, but I mean, while you're suffering from it, you have a constant ringing in the ear. The attack lasts anything from a few minutes to a few hours. You get a ringing, whining sound in the ear, often accompanied with hearing loss from that side, particularly the lower frequencies, the lower sounds. What else? You'll see vertigo. You'll see dizziness, nausea. But this tinnitus is the key thing that suggests it's this Meniere's syndrome rather than any other vestibular damage. Patients will often complain they've got the ear fields full. There's pressure on this ear somehow. Deep within the ear it's full. Increased pressure on one side. And whining, buzzing, ringing sound in that ear. Okay? We don't know what causes it, but the pathology basically is that you have, it's called endolymph hydrodrops. Oh yes, look there. Endolymph hydrodrops. For some reason, the patient produces too much endolymph in that side, in the ear, in the vestibular apparatus. So you've got increased buildup of endolymph into this vestibular system. You don't know why. So, there's nothing as a therapist you can do apart from recommend, referral, but they'll try things like salt-free diet. They'll try antihistamines, Dramamine, things like this. Some success, some not. In severe cases, where the patient's debilitated by this, they'll go in and destroy the vestibular apparatus. Surgically, they'll just destroy it. It's just they can't handle it. Symptoms are too great. They'll destroy that one side. And of course, they'll get vestibular symptoms, but hopefully you'll adapt to those, habituate to those. But that ringing is so debilitating, they have to destroy that vestibular apparatus on one side. Okay. Not much we can do about that one. We can do a lot about benign proximal positional vertigo, BPPV. You can get some amazing effects if you know what you're doing as a therapist with this. Benign means what? It's not going to kill you. So it's not, it's not terrible. Proximal means a sudden burst, a sudden attack. Positional, obviously the position of the head, vertigo. So these patients are people who report, I was emptying my dishwasher and I felt all nauseous and I felt sick. Or every time I make the bed, I bend over to make the bed, I get an attack of vertigo and I have to sit down for a while and I feel real sick and nauseous. Or I move, every time I reach up for my cereal at the top cabinet, I get all nauseous and I have to almost feel like I'm going to throw up. For hours they feel dizzy and they just have to sit down. But they find if they don't make that positional sudden movement. This one patient I had recently, a few miles away, the thing that provoked it for her was doing the laundry. And it was so bad in this lady, she couldn't go out the house because she lived on a very uneven road, lots of ups and downs, and bends, and she was homebound for months because every time she tried to drive in a car, or somebody took her in a car, she would go up and down like this and she'd almost be sick. It wasn't normal motion sickness. She was fine apart, she didn't motion it until she got this, and she was basically homebound for months and months and months because she couldn't not handle the nausea of driving down the road to get out of where her neighborhood. So what this is what causes it. As I said before, that remember on the macula, on the utricular saccule, you've got that jelly mass with those little bits of rocks on top. Those otoconia, those calcium carbonate crystals. The theory goes through trauma, for head, banging, or just for some unknown reason. Some of those float off. And because those utricular and saccule are connected to the semicircular canals, those little bits of rocks float away into the semicircular canals, where they should be, into the endolymph. Okay? They, of course, should be, that endolymph should be free of debris. So what happens, these little rocks land on the copula, on that jelly blob that is in those semicircumcanals. Remember that copula is supposed to be free floating in the endolymph. Same density, same specific gravity as the endolymph. So it does not move with gravity. So when you move your head, those rocks that are stuck on your copula make the copula move way more than it should. One theory says they land and stay on the copula. Others say they stay in the semicircular canal, and when you move your head, your copula bangs up against one of these rocks and knocks the copula over way too much for that amount of movement of the head. So when you quickly move your head, those rocks bang into the copula, or the copula is deflected anyway, way more than it should be, and you get this bout of vertigo, nausea, whatever. Okay? I don't know exactly the percent, I think about 90% of these BPPVs are found within the posterior canal. You do get it in the lateral and anterior canals too, but most of the situation, most of the time, you find it in the posterior canal. Okay? So the way you assess that, instead in your later classes you will go with this, you spend whole weeks doing this. This is the Hall-Pike-Dix maneuver. So you basically have the patient lying on a plinth, on a table, whatever. You quickly move them over the edge of the table, head in extension and side rotating. You can see how you're testing there the right posterior canal. Boom, twist them to the right, and then you just hold them there and watch. 5, 10, 15 seconds later, the eyes start twitching and the patient feels nauseous. Okay? It can be very severe, it can be mild. This position looks very much like what position? What else are you testing by doing this? Vertebral artery test. Very similar to vertebral artery test, right? So you can be careful. You know, if you close off the vertebral artery, you might get nystagmus too, because remember the vertebral arteries supply the vestibular apparatus and the cerebellum. Okay? So you can do the vestibular artery test how? Differently from this. You're all familiar with vestibular artery test? Yes? OT? No? So basically, if I twist my head like this, I am actually closing off this left vertebral artery. The right one is open, hopefully. So if I've got compromised right vertebral artery, and I do this to the patient, they might start getting nystagmus because I'm depriving the brain of blood, the vestibular apparatus and the cerebellum of blood, by doing this. If you think about if I push on my nose, like that, I'm closing off my left side. So I'm squeezing down my left vertebral artery here, so it now has no blood flow to it. The right one is fine. We'll get to this when we look at the cerebral blood flow. The right one's fine. Open up and I'm fine. But if I've got a compromised right one and I close my left one down, then I start getting these nystagmus issues. Fair enough? That you've been taught in PT? So if you want to do the vertebral artery test with your head stable to avoid this thing. You don't want to confuse BPPV with vertebral artery test. So I can keep my head stable and move my body around to close off my vertebral artery without doing that. Makes sense? You keep the head stable and you move the body to close the vertebral artery off, rather than moving the head. So that will distinguish between the vertebral artery issues and BPPV. That makes sense? You'll learn to do these tests later on. Okay, so you put in this position and the patient starts going, oh, let me up, kind of thing. And it can be very debilitating. This will make a person feel sick if they've got this issue. Let me know if you've had BPPV. No? It's quite common. Okay, so what do you do about this? There are some simple treatments that can be extremely effective in some cases. hopefully. Grant's exercises. I haven't done any one of these, but this is Grant's exercises. And I very briefly mentioned this, but this is where the patient basically goes to one side quickly. You can see how they twist the head upwards, and then go quickly to the other side, over and over and over again. Try to shake the rocks off the copula. Basically, you try to go back and forth, move into this provoking position. I never used it. The Siemens maneuver down the bottom there, when we look at the last one, you'll see why this it works, or supposedly works. You go over to one side, first position, down to the left on the diagram. You hold the head there for 3 minutes and shake it a bit. And then you quickly go to the other side and hold it for a few minutes. And then come up to midline. And stay in midline for 48 hours. Sitting up. You're basically trying to move the rocks off the copula. I've never used this one. This is the one I find is very effective. Epley's maneuver. Epley's maneuver. Or, there we go, or canalith repositioning. Epley's maneuver. This is quite useful, quite in many situations. So, you've diagnosed, you've got, in this case, a right posterior canal problem. So what you basically do is you start off in this Hall-Pike Dix maneuver position. You see how they're upright, twist the head, go down over the edge of the plinth. Okay? And you hold it there and shake their head, or sometimes you gently bang their head. Sometimes you actually put a vibrator on there. That vibrates the ear. And then you can see, you've got following A, B, C, D, E, etc., etc. You roll the head over the back of the plinth, here, into this position, and then sit them up. In LSU we had a model of vestibular apparatus where you put a little marble in these clear plastic tubes of the vestibular apparatus. And you can see, you can basically like a little game, a kid's game, you roll the marble around the canal and out. And that's what you're doing essentially. You put them in, for the posterior canal, you bang those rocks off the copula, and then while they're in the canal, you basically manipulate those rocks around the canal and back into the uterocosacral area. It takes those rocks out of that canal by doing this slow, vibrating them, and this hold, vibrate, and back into the position. And then they're supposedly to sleep, sitting upright for 48 hours. Some recent research has actually said you don't need to do that, but I've always done it. And I said I had this lady a little while ago who was homebound for months and months and months. And home health, this is a bit of a treatment problem, because I diagnosed this with this right-hand side posterior canal, this lady who didn't have a nice treatment table in her home. There's no plinth, high-low plinth, they use it. She was a very large lady, about 250 pounds. I did it in her bed, and her bed was rather than flat, with a big hole in it like this. And had a headboard and I had a footboard, so I couldn't hang her head off one side. I sort of had her diagonally across the bed, and I did this with her, whatever, on Monday, and she refused to see me on Wednesday. Because it was so bad. I made her so bad on... What will happen if you do this to a patient, they will feel sick as a dog, and they will hate you for it. They'll be sick for maybe hours or after. But after that, it'll probably take 2 or 3 sessions typically, 2 or 3 goes of this over a week or so to get out. With her, fix it in one go. And I said, really? Are you sure? She said, yeah, I'm better, please don't come Ben. I said, yeah, sure, but I did go and see her, but we did some other stuff, but we didn't do this. She said, no, I'm fine, don't touch me. But, I mean, are you sure you're not, it's just because you're scared of me doing it again? No, I'm fine. And she really was fine. For months and months and months, we've been homebound, did this treatment with her one shot. It took, 5 minutes the most. And she was cured of this issue, which she had been, for months and months she hadn't been able to get out of her home. And she went through these positions and she was fine. She slept in a big old lounge chair for a couple of days, and she said, yeah, it was fine. Apart from this initial treatment, which is very, very nausea-provoking, you know. You don't believe, like you warn them, this is really going to feel sick after this. And oh no, I'll do it, Ben, I'll do it. You can do this, and you know, it was okay then, and I left, but the rest of the day she felt really nauseous. But basically, it got those little rocks off that cuppa, and she was back to normal. And often it'll come back. I haven't seen her since, but often other patients have had, you know, 6 months later you have to go and do it again. So a top-up treatment, as it were. It's very effective if you know what you're doing, and it, you know, immediately change their life. And you'll learn to do this in sinus fractures. You can do this on all the canals. The posterior canal is the easiest one to do, I think. That's the most common one effective. Okay, that's enough of the vestibular system. That was supposed to take 2 minutes. Okie dokie. A couple more things to finish before we get to our disease of the motor pathways. Audition and olfaction. Very quickly through audition. We're not going to treat, obviously, deafness, but okay, so you all know how sound is perceived, right? I'm not going to go physiology. It's basically the eardrum vibrates, right? We all had this in A&P. Goes through the hammer. It vibrates the hammer, which hits the anvil, which vibrates the steward. Fair enough. Those are the Latin names, malleus, incus, stapes. That goes to the over window, and you get this pulse vibrating down the cochlea. Okay, so a wave of this endolent vibrates along the cochlea. Okay, so that's the transmission, that's the mechanical conduction. So there's mechanical conduction from the eardrum to the cochlea via those 3 little ossicles, those 3 little bones, right? So then this wave is sent up down the cochlea, and obviously the hair cells pick those up. There's a whole lot of detail about the hair cells and all this kind of stuff we won't go into. But basically the hair cells in the cochlea pick up this vibration essentially. And that's what we perceive, you know, that's how we initiate sound perception. Okay, this wave, this fluid vibration down the thing. Alright, so those hair cells, can't really see from this one, but there's these little, these are first order neurons coming away from the hair cells. They are bipolar neurons. Yeah, I can't see it there either. But these little, you can't really see them, but little blue dots here, those represent the cell bodies of these hair cells. And those are found in what's known as spiral or cochlear ganglion, which is right in the cochlea itself. It's not near the brainstem like the other cranial nerve nuclei. So that spiral ganglion, or cochlear ganglion, is the equivalent of our dorsal ganglion. It's right in the ear itself, rather than next to the spinal cord or next to the brainstem. You can see it there, spiral ganglion. Okay? So those are the end of the hair cell. That's the first order neuron. Comes in down the auditory part of the vestibulocochlear nerve into the pons. That's the first neuron conveying that sense of sound into the pons. Where then synapses with both the dorsal and ventral cochlear nuclei. Okay? Both of them. They're sometimes called ventral and anterior, posterior, whatever, in some texts. Okay, so it's into the pons. Second order neuron takes over, goes up bilaterally, crossed and uncrossed pathways. From one side it goes up the left and the right, from both these nuclei, up what's known as the lateral lemniscus. Going to send to the brainstem the second order neurons bilaterally, and it's going to go to what is, for conscious perception, what must we go through? Thalamus. So you can see there, it's going to the medial geniculate body. On this side it shows it. By the thalamus. What goes to the lateral geniculate body? What sense? What sense goes to the lateral geniculate body? Sound goes to the medial geniculate nucleus or body. What goes to the lateral? Come on. Vision, right? Remember? From there you get the optic radiations. What goes to the VPM? What goes to the VPL? Okay, there's an exam question. Why not? You need to know what goes to the posterior posterolateral nucleus. VPM, remember? Trigeminal nerve, the VPL, because all that stuff from the body goes to the VPL. Remember all the sensation pathways? You haven't got that already, have you? Okay, so remember what goes to what part of the thalamus. So medial geniculate body here. And then just like the third order neuron, just like in all of the sensations, projects out onto the cortex somewhere. And these are sometimes called auditory radiations. Just like we had in the visual system, we had optic radiations, didn't we? These are auditory radiations going out onto area 41, 42, just below the lateral fissure on the superior temporal gyrus. Remember here, the superior temporal gyrus, that's where we have our primary auditory reception area. Okay? That's how we get conscious perception of sound. Simple. Notice it's bilateral. So the right ear sends signals to the left and the right cortices. The left ear sends signals to the right and left cortices. So if you have a stroke that destroys the superior temporal gyrus on the left hand side, you're not deaf. Because the right hand side is also hearing that information. Okay? Okay, you can see there are also collaterals that go to these two fellows here. The inferior colliculi. Why do you want to go there? Why do you want to send information, sound information to our inferior colliculi? Auditory reflex, right? Auditory reflex. This is part of the corporal quadrigeminate, remember. Visual reflexes are mediated by what? Superior colliculi. Inferior colliculi. It mediates auditory reflexes. So you hear a loud boom or slam, or a door slams, and you flinch. It's the inferior colliculi that did that to you. Make you flinch as you hear a loud explosion, whatever it is. What tract will do that for you? What tract makes you go like that? Tectospinal tract, emanating from this checkral area and the inferior colliculi. Okay? So very simple. There's a lot more detail on that, but we won't go into. So remember where sound is projected to. Remember it's a bilateral projection. Okay? If you cut the nerve out here, of course, you are going to get you're going to have problems from this ear, but you're going to get this sound from this ear is going to present to both cortices as well. Okay? But you'll have deafness in one ear. You'll still be able to hear, but you'll hear from the other ear. You'll have deafness in that one ear. Two types of deafness. They're sort of categorized into conduction and sensorineural deafness. A conduction deafness is due to a mechanical problem. Mechanical impediment to the transmission of sound. And usually the most common cause of that is otosclerosis, which is basically fusing of usually the stirrup itself. Those little ossicles don't vibrate. So these fellas, the mechanical conduction across those is impeded for some reason. And usually the stirrup becomes fused. Okay? So the stirrup can't vibrate into the oval window. That's a mechanical problem. That's called a conduction deafness. You might have a torn eardrum. That would be a conduction deafness. There's no mechanical transmission of sound. The vibrations cannot be transmitted into the cochlea. Sensorineural deafness now is not mechanical, it's a neural problem. You have a problem with the cochlear nerve, for example. So your cranial nerve is damaged. The cochlea itself might be damaged. You're getting the vibration into the cochlea, but it's not signaling that nerve, or the nerve's damaged. And that would be called sensorineural deafness. It's a nerve problem rather than a mechanical transmission problem. You can test which type of deafness the patient has by using a tuning fork. If you whack a tuning fork and hold it next to the ear, they're going to hear it, okay, on one side. That could be either of these. It could be conduction or it could be sensorineural. Alright? But then if you get the same tuning fork, you whacked it and you place it on the skull by the ear. So it vibrates the skull now. Very, very high frequency vibration. That will transmit signals to the cochlea even though you have conduction deafness. Okay? Because you're bypassing the vibrations of those little bones by taking it straight to the skull itself. So if you then can hear it, so I bang my tuning fork in midair and I can't hear it. I stick it on my bone and I can hear it. That suggests it's conduction deafness. Okay? Because I'm bypassing the little bones vibrating by going straight to the skull itself. If I still don't hear it when I'm stuck on my person's head, it's probably sensorineural deafness. The nerve shot. I'm getting vibration to the cochlea, but it's not signaling the brain that I've got sound, and therefore we're saying it's a sensorineural deficit. Many causes of that nerve damage. Children, commonly rubella infections during pregnancy. So, I mean, the mom has rubella during pregnancy. The kid sometimes can be born deaf. Sensorineural deafness. Large doses of antibiotics can kill the auditory nerve. Neomycin has been shown to do that. In aging, the cochlea can gradually degenerate. So in old age, just like in vestibular hyperfunction, you can get deficits in the cochlea and the hair cells just because of the aging process. What else? Acoustic neuromas. Acoustic neuromas, which is a tumour on the nerve itself. Acoustic neuromas. A tumour on the nerve itself, usually one of the glial cells, and you can basically cut off that nerve. Acoustic neuromas, they're not uncommon, unfortunately. Olfaction. Smell. Very, very briefly. This is the most complex pathways there are in all our senses. So we're going to go very, very simply, cut out all the detail, we'll be here all day, talking about the weird, complicated pathways, because we've inherited these from lower animals who've got, smell is the most important sense to many, many animals. It's not for us, I would say vision is, but we've got remnants of these weird and wonderful pathways that go all over the place in the brain, in the brain center. Anyway. Okay, so let's look at the very basic gist of the olfactory system. This is at the top of your nose here. So here we are. This is the top of the nose. This is the cribriform plate. This is the top roof of the nose here. This is part of the ethmoid bone. The ethmoid bone, part is called the cribriform plate. It's like there's little holes in it. Okay? For projecting through those holes are these olfactory neurons, olfactory cells, these yellow ones here. Don't try and think of first order, second order, third order neuron with this mess. It's just too complicated. Okay? Those neurons terminate in these vesicles with little hair cells on them. Little dendrites, not hair cells, but dendrites sticking out. Okay? We have only about 10 to 15 of these olfactory neurons on either side of the nose, left and right. Only about 10 to 15 of them. Okay? And they continually die. So these basal cells, these blue fellas here, make more olfactory neurons. And how they do that and why they do that is a subject of a lot of research. Because this is the only place in the nervous system where we regrow neurons. It would be fantastic if we would regrow neurons in the brain or in the spinal cord. A lot of us would be out of jobs then. If you treat neuro patients, we would not have a job because we just fix ourselves. We grow more nerves. It'd be great. But we can't do that, unfortunately. Except in this one weird place. Okay? And those basal cells that are basically budding off new olfactory neurons, olfactory cells every 60 days. Every 60 days they produce another neuron which somehow learns to grow through this hole in the cribriform plate and attach to the olfactory bulbs. Make connections with what's known as these brown line here are mitral cells. The mitral cells. Very well there. These are called mitral cells here. And that olfactory bulb goes into the olfactory, forms the olfactory tract, which is this thing here. Which is not really a nerve. The olfactory bulb and olfactory tract really is an extension of the brain. So there's no first, second order, third order neuron kind of stuff here, really. Well, it's more complicated. So, let's go back to this diagram again. These green fellas here, these Bowman's glands, secrete mucus, that green stuff that the chemicals of smell dissolve into. Those little dendrites, about 6 to 8 of them on each neuron, sample that mucus, detect the smell substances within the mucus. They then transport upwards. You see how these olfactory cells, olfactory neurons are bipolar, yeah? Up to the mitral cells here. These then take the signal back into the brain. Okay? Now where it goes from there, is anybody's guess. Well, it's not, but it's a mess. It goes all over the place, this smell. I'll pick out a few places where we send our smell information to. Are those olfactory neurons, are they rapidly adapting or slowly adapting, relatively speaking? Rapidly, fortunately. When you're in a stable shoveling whatever it is, horse poop, cow poop, whatever it is, you can shovel, after a few minutes are in there, you don't smell it, fortunately. You carry on shoveling all day long and you're fine. Okay, imagine if that smell was with you for hours on end. Fortunately, cells rapidly adapt and we get used to it. We don't smell that anymore for a while. So where does this stuff, this sensate of smell end up? Well, we know very complicated pathways, but we know some of the places it ends up is in the hippocampus. Smell projections go to the hippocampus and the amygdala. The amygdala and hippocampus. You've heard those terms before? Amygdala, part of the basal ganglia in some books, and hippocampus. Those are part of the limbic system. What do we know about the limbic system so far? Memories and emotions. Memories and emotions. This is why smell is a very emotionally provoking sense often. You smell something and you go, oh, that reminds me of, my mum, or when I was a little baby or kid, whatever, that smelled like my mum's bread or something like that, whatever, and it brings back these emotions, and very deep-seated memories go along with smell. Very emotional provoking. Because smell goes through this limbic system. We eventually, to get conscious perception of smell, the pathways are very vague, but we know it goes to the medial dorsal nucleus of the thalamus. The medial dorsal nucleus. Eventually it goes to the thalamus, and then our conscious perception of smell is thought to rely on the orbitofrontal cortex, which is this word there. The orbitofrontal cortex. Orbitofrontal. Orbits, frontal lobe. And that is basically here. Right above the eyes. Right there. The orbitofrontal cortex. That's a very mysterious part of the brain. A lot of weird theories about what that part of the brain does, as well as consciously perceived smell. A lot of that decision making, decision making skills are thought to reside in there. But this is where we get that smell information consciously perceived, the orbitofrontal cortex. Couple of clinical things, then we'll move on to the pathways. Osmi means Greek for smell. Okay? Top word. Osmi is Greek for smell. So, hyposmia would be what?
Inability to smell?
Loss of smell. Loss of smell. Less than normal smell ability. You get a cold. You lose a sense of smell there. Parkinson's disease. Aging. People have a loss of smell and aging, which is, of course, is very highly correlated with taste. If you can't smell anything, your ability to taste is greatly diminished, right? You must be aware of that. And that, I think, is one of the issues with the aging population. I've had quite a few patients who I treat in home health who just don't want to eat. I had one bloke the other day, a few weeks ago, who died on me. Failure to thrive. Nice, fantastic bloke. I was treating his gait, and he was a guy who'd have to, on his walk, who'd have to bear all his weight on his arms, and he'd drag his feet across the floor because he couldn't pick his feet up. We worked on eccentric contractions and hip abductors. Remember we talked about this? You cannot make any concentric contraction, but he could make eccentric contraction. He gradually worked, increased his strength in hip abductors, and he was walking better. But he basically didn't want to eat. Didn't taste good. It was like eating cardboard. He couldn't taste it. He couldn't smell it. He couldn't smell it. He couldn't taste. And eating was like this. He had to force himself to eat because he didn't really feel hungry. He didn't like eating this cardboard stuff, whatever it was. He didn't taste anything whatsoever. And I treated him one Tuesday, Thursday. So one Tuesday, and he died because the diagnosis was failure to thrive. Nice bloke, I was one of his best buddies because all his family had died, and he told me stories about working in the Navy and all this stuff. But he basically didn't eat, and he got so skinny. And we see patients, cadavers, who they diagnosed as failure to thrive. Basically, couldn't taste, couldn't smell, and he just died because he basically didn't eat anything. He had no energy whatsoever, unfortunately. Anosmia is complete loss of smell. this can occur through various things, but one of the ways it can occur is fractures to the cribriform plate. If you break this, you can lose, sever those nerves, and you can lose a sense of smell. I had a mate, we went rock climbing in the Alps. We were on a big massive cliff, and he was leading, I was seconding. He fell, and his protection failed, and he slammed his face against the rock, and he broke his ethmoid plate. I could tell because he was oozing cerebrospinous fluid out of his nose. So remember, this olfactory tract bulb is an extension of the brain. It's surrounded by the meninges. So you can, if you break the nose or break very badly this cribriform plate, you can sever the meninges around here. And a serous, like egg white was coming out of his nose. It wasn't, hoovers, whatever, it wasn't normal mucus. It was much light, runny. It was running down his lips. So we had to have him, when airlifted out of the helicopter came and took him. He had, problems there. Frontal lobe tumours. Remember where his olfactory lobe is, this olfactory bulb is? Right underneath the frontal lobe. So frontal lobe tumours, or damage the frontal lobe somehow, can damage the olfactory system. Okay? If you suspect frontal lobe damage, or you suspect smell, if the patient has sudden problems with smell, one of the things you should look at is there a problem with the frontal lobe. What else would you find in your patient who has frontal lobe problems? Behavior, personality change, right? Remember Moniz and his up the nose and wipe the frontal lobotomy? He was trying to change these psychotics. Frontal lobe personality, frontal lobe damage, personality changes, smell issues. Cacosmia. The problem with smell. What's cacosmia? What's cacophony? Same root. Cacophony, massive, obnoxious noise, loud, cacophony of sound, right? You've heard that term? No? So, yes, no. Cacophony, like, in the morning the birds are going crazy, like that's a cacophony, obnoxious noise. So, cacosmia is obnoxious, or olfactory hallucinations. Olfactory hallucinations. This can be frontal lobe, but more often than not, it would be damage to the medial temporal lobe. So where these, again, I've gone over the hippocampus and the amygdala, that's the medial temporal lobe stuff, right? That's where it sits. We're looking at the medial temporal lobe damage. So a patient, for example, has seizures, epileptic seizures in this area of the brain, in the medial temporal lobe, and the inside the temporal lobe, the inside surface of the temporal lobe, okay, could have cacosmia. Disgusting olfactory smells. There's nothing there, but you think there is. No, it's not me. It's him. Cacosmia. You must have cacosmia, honest. Nothing to do with me. What else would you find with this patient who has cacosmia due to a medial temporal lobe lesion? And that often is known, this serious symptom, George Gershwin syndrome. Remember him, a composer? He died of this. He had a medial temporal lesion, mass lesion in the medial temporal lobe. It killed him eventually. He complained of cacosmia. What else would he complain of? Think about the medial temporal lobe. What sense goes through that?
Vision.
Vision. What part of vision? Myers loop, right? Which is carrying what information?
Upper visual field.
Upper visual field. So what would be the deficit the patient will present with? If it's a right medial temporal lobe lesion, they would get left or right problem. Right medial temporal lobe, left or right problem first. Right medial temporal lobe, right cortex sees which side of the visual field? Left. So left visual field problem, right? And it's going to be medial, the lower part of the brain there, the lingual gyrus, mind loop, upper, so it'll be right superior homogeneous quadrantenopsia, wouldn't it? Quadrantenopsia. We did this in we looked at vision. The visual Myers loop. What does right Myers loop take? Okay? Visual field information from the contralateral visual field. For the upper visual field, you'd lose that. So you'd see those triangle, that quadrantenopsia. So we had that. Those two things, cacosmia, quadrantenopsia, you think medial temporal lobe damage. Okay, we've got 10 minutes. Let's just do an intro to our pathways. We're looking at lesions, diseases of our motor pathway. That's our next big topic. Okay, quick review. Motor pathways. We're looking at pyramidal pathway, we're looking at extrapyramidal pathways, we're looking at corticobulbar pathways. Okay? Pyramidal pathway, where does it start? Where does the pyramidal pathway start? Motor cortex, right? Motor cortex. There's our motor cortex. So our topically organised motor cortex. Remember where the foot is, where the hand is, where the face is. Different places on equal representation on that motor cortex. Okay? So our cell bodies of those neurons are going to go into the lateral corticospinal pathways, and the anterior corticospinal are coming out of here. The corticobulbar tract goes where? The corticobulbar tract goes from where to where? Motor cortex to brainstem for control of our cranial nerves. So our muscles of our face, for example, come out of here. The upper neurons of the facial nerve come out of here and go down into the brainstem. The extrapyramidal pathway starts lower down, doesn't it? Starts at the basal ganglia, other nuclei. What are the tracts that make up the extrapyramidal pathways? Tectospinal, vestibulospinal, rubospinal, reticulospinal. Start lower down. We can have diseases in all these systems. Parkinson's disease, extrapyramidal pathways, right? Basal ganglia. Cerebral palsy, typically the motor cortex area. We're going to look at these. So there's the upper motor neurons. Remember upper motor neurons. Signs and symptoms, upper motor neurons. You must remember those. Give me 4 or 5 signs of upper motor neuron. Babinski, Clonus, Hoffman's, spasticity, hyperreflexia, etc., etc. Lower motor neuron, flaccid paralysis, fasciculations, muscle atrophy, etc., etc. No reflexes. Okay? So, here is our pyramidal pathways, remember. Coming out of the motor cortex, quick review, down to the internal capsule. Most of them cross over the decussation of the pyramids medulla to form a lateral corticospinal tract. The other ones do not cross over, count as the anterior corticospinal tract. Most of those will cross over at the segmental level. A few stay ipsilateral. Okay? Let's look at a little bit more detail. Just a touch more detail, and then we'll lesion this to what happens. Okay. The motor cortex itself is arranged as 6 layers of it, from superficial to deep. The motor cortex, the whole of the cerebral cortex has 6 layers. So here is the cross section through the cortex cortices of the brain. This one is our motor cortex. This was a motor cortex here. 6 layers. There's cells starting within the cerebral cortex, these layers. Most of our pyramidal tract neurons start in layer 5. You can see these big blue blobs here. That is the cell body of those multipolar neurons that go into the pyramidal tract. This is where they get its name from. The pyramidal tract does not get its name from going through the pyramids and medulla, because it's named after these huge blue pyramid-shaped cell bodies of these neurons. That's where it gets its name from, the pyramidal neurons. Those are the neurons that are going to project out of the cerebral cortex down to the spine. Okay? And this is how they get down there. They go through, they converge at the internal capsule, remember. And that's all we've talked about the internal capsule so far, haven't we? But the internal capsule is between the basal ganglia and the thalamus. This is all we've talked about so far, I think. So this white tract here is the internal capsule. So all these neurons converge as a bottleneck in the internal capsule here. This is a transverse plane view of the internal capsule. On the bottom diagram here. It looks like a leg. That's what they think it looks like, I don't know, whatever. This is the diagram we need to look at here. So supposedly, what they'll term it is the anterior limb, the posterior limb. It looks like a thigh and a shank, lower leg, supposedly. So look, I should have blown this off. But here is the thigh. That's the anterior limb. There is the lower leg, the posterior limb, and there's the genu, which of course means the knee. Shaped like a leg bent, as it were. Now the reason why this is important is our neurons go through, our pyramidal tract neurons go through the posterior limb. Go through the lower leg, as it were. They go through the posterior limb of the internal capsule. And they go through there in a somatotopically organized fashion. Okay, last point. Remember this, F-A-L. F-A, face, arms, legs. The face information, corticobulbar tract, is going to go through very close to the knee, the genu. Behind it becomes the arms. Behind that comes the legs. So the body is mapped down that posterior limb of the internal capsule. The internal capsule is very prone to strokes. Very prone to strokes, unfortunately, because there's lots of little arteries that go there that come off bigger arteries. So little bits of fat, plaque, clog the arteries going to the internal capsule. If I clog my internal capsule on my right hand side, what would I see? Last point. I've given you a stroke that affects the whole of your right internal capsule. Where would you see the symptoms appear? Left side. You would have upper or lower motor neuron regions. See symptoms. Upper or lower? Upper. You would see the these clones, etc. Okay? We'll go over that again next class and look at some lesions of this area of the